So, as you all know, pediatric movement disorders comprise a large group of heterogeneous neurological disorders presenting during childhood until adolescence, like tics, myoclonus, ataxia, chorea, dystonia, Parkinson's, but often with mixed phenotypes. And diagnosis can be quite challenging in this age group. This is due to either overlapping phenotypic presentation or due to variable phenotypes within the same family, as Professor Dr. Huda, of course, touched base on this thing. Other phenotypic variability is mainly due to variable penetrance and or variable expressivity of the same mutation. Other factors could be involved, actually. They could be related to age age variability in phenotypic presentation. It could be related to lack of expertise and could be related to rarity of the disorders or the limited resources for genetic analysis in our region. So I'll go through this diagnostic approach, which is a very nice algorithm I came across in Brandsma and his colleagues, where they suggested first that we need to clinically identify movement disorders and to ask ourselves like 4 questions. First of all, whether it's a movement disorder or not. We need to identify and classify the phenotype of the movement disorder. And sometimes we do have more than one phenotypic presentation of movement disorder in the same patient. So we need to identify the most predominant or the most disabling one. And we have to ask ourselves whether it could be functional movement disorder, and this should be a positive diagnosis and not a diagnosis of exclusion. And if ever we were able to determine the clinical syndrome. Later, we have to ask ourselves about what are the diagnostic tests that we need to perform to reach a diagnosis. So can this movement be disorder due to acquired or secondary causes? And that can be, of course, we will elicit this later in the coming slides. Does the clinical syndrome fit a treatable inborn error of metabolism or treatable movement disorder? It's very important in order not to have this regret feeling if I've missed ever a treatable movement disorder. Of course, in this, like we have seen how far genes are affecting our treatment plans. So we need to consider genetic testing, and sometimes we don't have a definite answer, and we need to go for further genetic assessment and functional studies. So starting with the first question, my presentation starts with very basic information, and later on we'll take more complex cases so that we cover all the areas. So first we have to ask whether is it a movement disorder or not. So we have to look for whether it's a normal physiological motor patterns versus pathological movement disorder. For example, in infantile fidgety movements and startle reactions that we can see it and can be easily misdiagnosed with myoclonus or chorea. Typically, this disappears by age of 3 months. We can have a child who's presenting with dystonic-like features, which can persist up to the age of 16 years. And we can have also these goal-directed movements that can be easily misdiagnosed with ataxia-like features. And this typically start at the age of 3 to 6 months and disappear by the age of 16 years. However, how we can identify and distinguish this, typically these movement disorders, these physiological motor pattern will typically subside by time. And you can see typically the child is developing, showing a good psychomotor development. Taking in consideration a very important thing, then sometimes movement disorders might be mistaken for epilepsy. And we, of course, I'm sure that most of us have seen patients who are presenting with movement disorders and mistreated as a case of epilepsy. The second thing, we need to be minded with the phenotypic presentation, which we have 3 major groups in order to make our life a bit easier. So we have the hyperkinetic group, we have the hypokinetic group, and we have the ataxia, which is neither hyper nor hypokinetic. So I'm not sure, yeah. So the hyperkinetic group, which is the most prevalent group among the pediatric age group, coming from dystonia, chorea, myoclonus, tics, and tremors and stereotypes. And we have the hypokinetic disorders, which is rare in the pediatric age group, such as Parkinson's disease, where it presents with the core symptoms of bradykinesia with occurrence of tremors, rigidity, or both. Mostly in juvenile Parkinson's disease, the tremors is static tremors. However, action tremors have been also reported. And then we come to the ataxia again, which is neither hypo nor hypokinesia. And this is a relatively common disorder in the pediatric age group. And it has 4 domains, whether we have gait and stance with a broad ataxia, gait, swaying gait, and staggering, or we have the kinetic ataxia with intention tremors, dysmetria, or dysdiadochokinesia. And we can have also eye movements with nystagmus or with sagatic intrusions and dysmetria, or cerebellar dysarthria. Take in consideration, things is not easy as we think. Sometimes pediatric movement disorders can present with paroxysmal movement disorders, with typically an events or episodes of involuntary movements that occurs at certain times and then they disappear, whether it's either part of an isolated neurological disorder or a more complex one. And have you seen also paroxysmal movement disorders? It can include paroxysmal dyskinesias, attacks of dystonia, chorea, choreoacetosis, choreic dystonic movements, and cerebellar ataxia as well. So just this is basic videos for if ever there is juniors here. So the first, we will go through the some videos to elicit more on hyperkinetic movement disorders. So the first girl here, this is typically, she has tics, which is described as sudden, rapid, repetitive, non-rhythmic, voluntary movements, or sometimes it can come into vocalization. So it can be classified either simple tics or complex tics based on the group of muscles involved, or even simple phonic tics if it's just involved like sniffing sounds, humming sounds, or it can be more complex with saying certain words or syllables or phrases. In this particular child, sometimes tics could be challenging. As you can see, she has like these myoclonic jerks of the shoulder. So should we do EEG? Should not we do EEG? So the history is very important because classically, tic disorder has a waxing and waning course. And also it's very important to know that they have this premonitory sensation of urge to do the tics, and it is suppressible that is usually typically followed by rebound or release phenomena. Next will be motor stereotypes, which is non-goal directed motor stereotype patterns. It can be vocal as well. In the form, it's usually purposeless and occurs over a period of time of seconds up to minutes. It can occur in the form of stretching arms that you can see. She's opening her mouth, stretching her face. So this is typically for stereotypes. The only thing in stereotypes we have to observe for the development of the child. It's very easy to pick up stereotypes in children with autism spectrum disorder, but sometimes you can see it also in normally developing children. Then coming to the myoclonus, which is the fastest movement disorder, and it is usually occurs in the form of brief excess jerky involuntary movements. And as you can see, these siblings both have myoclonus in their hands. And also one of the clues is that this myoclonus, sometimes it will get worse on goal-directed movements, and it can be elicited as well with tactile stimulation, as we'll see in this video. Myoclonus can be classified according to origin, whether it's cortical, subcortical. Cortical is the most common form, subcortical, spinal, or peripheral myoclonus. And you can see here the child has difficulty with the finger-to-finger test, and on tactile stimulation, it can elicit the myoclonus. Okay. Next will be chorea, which is a brief, continuous involuntary movements where the child, you can see, give the appearance, since it is continuous, give the appearance of restless appearance. And one of the diagnostic clue, when you ask the child to do some goal-directed movement, it can get even worse. And sometimes it affects the gait, where you see the children having this swaying or dancing like gait. Okay, move to the next, which is dystonia, which dystonia actually is we see it a lot in our practice. I'm not, because maybe we are pediatric neurologists, but this is it described as sustained muscle contractions, either or it can be a continuous sudden muscle contractions that will result into a sudden change in the posture or posturing. And the clue is that sometimes when you are thinking of dystonia or dystonia mimickers, the dystonia get worse on initiation of movement. And one of the greatest dystonia mimickers, of course, is spasticity, which can be diagnosed when we do find the velocity-dependent hypertonia, pathological reflexes. And in this boy, you see that he has a retroflexion dystonia, and he has this sensory trick. So it's well known that dystonia, you can have a sensory trick when you hold certain part of the body or the face, the dystonia symptoms can be alleviated. Okay. Now, coming to the tremors, which is characterized by rhythmic oscillatory movements, involuntary movements. You can see tremors involving the arm, the face, the legs. And typically, they get worse also when we ask the patient to reach for certain goals. So it will show increase in the tremors. As you can see with finger-to-finger test, the tremors will get worse. Okay. Now, the less common movement disorders pediatric age group, which is the Parkinsonism, and as I mentioned earlier, the core symptoms would be bradykinesia with tremors and a rigidity or both. And you can see the child has difficulty rising from the chair. He's very slow. He will have very slow stooped gait, decreased arm swing. So please look at you almost no arm swing while he's moving. Sorry, it will come there. Yes. I hope it's clear. And then if you ask them to do like a finger tapping, you'll find that the finger tapping is very slow. You can move faster if you want. I can skip the tapping. Yes, it's here. Okay. Okay. Next. This is the ataxia, which is neither hypo nor hypokinetic movement disorder. We can see this girl with a wide-based gait, and sometimes this gets worse when we turn around or she wants to do a faster movement. It can be associated also with some intention tremors and as it will show in the video. This is the intention tremors, and then later we'll show the dysdiadochokinesia. Okay. Just I'll ask a favor for the future slides, like the cases, please don't videotape because the consent only for the presentation. Okay, thank you. The next question, whether it's functional or not. So we have to ask ourselves whether it's hyper or hypokinetic movement disorders. We have to look at the onset, whether it's abrupt onset, whether the symptoms vary in severity or not, whether it is distractible or not. And also we have to think that functional dystonia, also the posturing is frequently fixed instead of having being mobile. We have to ask also about history, take a very detailed history, whether there is any preceding medical symptoms, prominent pain, patient has paroxysmal symptoms, sometimes physical and psychological triggers, and selective disability. And sometimes it's really very, very challenging to have to identify whether it's functional or non-functional because they can coexist in the same patient. Now, we need to also look for other clinical syndromes. So if we have a constellation of clinical features where we have different movement disorders, we have neurological signs such as spasticity, epilepsy, visual or hearing impairment or cognitive difficulties, or we have non-neurological symptoms such as facial dysmorphism or psychiatric or skin disorders, then we need to think of clinical syndromes. Now, the next step will be the diagnostic approach, which is, I will go through the questions one by one. So the first thing, we need to look for acquired causes. So we need to take, again, a thorough history of drug intake, ask if there's any family member or a grandparents who are taking medications. We sometimes need to do imaging to rule out vascular or inflammatory or traumatic or autoimmune disorders or metabolic disorders, and of course, lab serology and CSF for autoimmune and infectious disorders. We need to think of treatable inborn errors of metabolism when we have more than one movement disorder involved, when we have more than multi-organ involvement, cognitive difficulties, or worsening of symptoms by fasting, infection, or dietary changes, and triggers if ever they have any triggers such as exerting this movement. And this is actually a very nice table. Of course, I will not go through this table, but some of the movement disorders have been described with Dr. Ahmed biotinidase deficiency. In the next table, also, we have other many treatable movement disorders that can, inborn errors of metabolism that can present with movement disorders. So we need to be aware and minded of treatable ones. Now, the diagnostic test, I'll go through this very fast because I think it's covered in the previous talks. Genetic testing is very important. Single gene mutation or target sequencing need to be considered only when we have a positive family history or we have a clear genotypic phenotypic correlation and we're suspecting a specific syndrome or disease, or we can go for comparative genomic hybridization. To be honest with you, I go for NGS and whole exome sequencing because it gives a better coverage. It's more cheap and faster. Then we have also the hassle of having variants of unclear significance, or we have the patients who have heterozygous mutation in genes with autosomal recessive inheritance. So sometimes we need to still to do a movement disorder filtering the phenotypes, and we need to do more functional studies, as I will show in one of our cases, I think, or two of our cases. Okay, so this is the deep dive in case scenarios. So I encourage international speakers, if they didn't have the got to Ras Mohammed Sharm el-Sheikh, this is the biggest brain coral, and for Egyptians also who have never seen this, this is the biggest brain coral in Ras Mohammed, in Sheikh Ras Mohammed, yes. Okay, so our first case, this is an 18-month-old boy who presented to our clinic with the diagnosis of cerebral palsy and refractory seizures. He has poorly controlled seizures. He was diagnosed as hypoxic ischemic encephalopathy, daily events that I will show on the video, and sleep difficulties. And for the sake of time, I play the video while I'm speaking about the history. So he was born 39 weeks of gestation. This is his Apgar score. He was admitted for 2 weeks in the neonatal ICU for hypotension and was noted to have less eye opening. He had normal neurological examination at that time. Soon after discharge, he had these daily events of severe stiffness all over the body, as you can see, where he is sweaty, flushed, and he will have also these movements in his eyes. 1 second. Fine. Yes. Trying to play the video. This is very important. لو سمحت. مش عارف. لا مش راضي يشتغل. اقفل ده الاول. طيب خلينا نقفل ده اهو. اوكي. ده لسه هنستناه، ما اقدرش اواكب. نستناه ويخلص كله. في ناس نامت طيب اوكي، هي مها مانج ان هي تخلص الفيديو بسرعه. اوكي بس كده. استني، لا اتس اوبننج. اطلع بره. اوكي خلاص. I will play this first. Yes. طيب ما المشكله، انا مش عارفه هو بره فين. ممكن تساعدنا أنا؟ طيب يس ابعد. ايوه العب لي بقى ده. لا خلاص دوس عليه بقى. بس شوفوه دلوقتي كده وبعدين هنكمل. اوكي so you can see the eyes is fixed. ليه خلاص خليه يلعب كده يعني to play this way. You can see the eyes is fixed up. He has upward gaze, so this could be seizures. Why not? Okay, let's see. What do you think? Anyone has a clue? Perfect. This is oculogyric crisis. Yes, and 10. So this is the medication that he has been receiving. He has failure to thrive. He's alert, irritable, and he was responding to playing in between these events. He can fix and follow. He has mild ptosis and right eye exotropia. He has examination significant for generalized hypotonia, poor head and control. His reflexes were listed all over, and he has daily events of seen in the video. Those seen in the video. The investigation and workup was completely normal. Cardiac echo, everything, and it turned the West analysis showed pathogenic homozygous mutation of the DDC gene. Okay, and this gene, according to the consensus, we have to have other supplementary additive investigation. So we found that the patient has low enzymatic activity of the L-aromatic amino acid decarboxylase enzyme activity, which is very important to make such a diagnosis. I'll show in the next slide. So commonly, these patients present with hypokinesia, hypotonia. They can have also oculogyric crisis, developmental delays, ptosis, excessive sweating. They can have less common manifestations similar to what we have in our patients: sleep disturbance, irritability, dysphoria, autism-like symptoms, and they can have non-neurological symptoms such as gastroesophageal reflux, which at some point the patient was diagnosed with GERD. Okay, so what is AADC deficiency? So this is a rare inherited disorders and neurotransmitter synthesis, and this will result into the reduced formation of dopamine and catecholamines. And as of you all know, catecholamines and dopamine is very essential for the motor development and cognitive and behavioral developments. So that's why we see all these manifestations, and this is the consensus guidelines that we have at least 2 or 3 core diagnostic tools. Either the genetic tests have to be one of them. We have to have either low plasma enzyme assay level, or we have this CSF criteria, which for the sake of time will not go through the details. This is the clinical case summary, how we should think of our cases. And for the sake of time, I'll just skip the slide. This is symptomatic treatment, and typically we were only giving this patient symptomatic treatment, first line dopamine receptor agonist, MAO inhibitors, just to keep the dopamine level high, and we can give anticholinergic agents and melatonin for disorders of sleep and central alpha agonists. However, our patient actually received clonidine and it got worse. And of course, rehabilitation is very important. Until this is, of course, many clinical trials that have been looking into like gene therapy, and I will not go through this, but finally in July 2022, the European Union granted the approval for Abstaza as a gene replacement therapy, which is injected through intraabdominal injection, whether through surgical approach or through stereotactic approach. So this is why this is important to recognize, because it has treatment. Eventually, it's very aggressive, but this is the way. The second case, which is very, very interesting case. I love this case. So this is, لا ما هحكي لك قصة طويلة بس. Okay. Okay, so the second case is a very wonderful Moroccan boy. He presented to my clinic at the age of 4.5 years, and he was also received the diagnosis of epilepsy, was maintained on levetiracetam. His developmental history was uneventful. Parents were first cousins. The elder brother has intellectual or learning difficulties, and he has one healthy girl sibling. So he have 3 types of events. I will start in a chronological manner. The first event, which I never witnessed at the age of 4 months, he had this uprolling of eyes, stiffness all over the extremities, which have been treated as seizures, and he was maintained on valproic acid, and he remained seizure-free. And these events stopped completely at the age of 18 months. The second event, which used to occur on annual basis, this one I witnessed actually in the, I don't know why it's inverted anyway. So the patient will have an episodic annual events of being, having imbalance, ataxic gait that would last for 10 to 15 days, and it will subside on its own. And he received lamotrigine or Lamictal for this, but it didn't help these movements. And you can see also in the second video where he has problem reaching for the toys. And just for the sake of time, I will show you when he tries to attempt to get from bed, he's unable to get from bed. Okay. The third event, which is a really very challenging event. So he used to have these daily events that mostly triggered by movement or exercise. And he will have this at least 8 times per day. We'll have this facial movements, this kinetic movements, and it involves the arm as well. I will show in the next video. And these movements would last for a few minutes, followed by sneezing or yawning, and then it will stop on its own. The examination was normal, apart from the 10 to 15 days where he had the ataxia and the slurred speech. And we were lucky enough to be able to capture this event during the EEG. So the EEG will not show, but it's clear from any electrographic changes. But I wanted to show you more about the movement disorder that he has. So he's playing with the chair. And then all of a sudden, he will lose the balance. So he will start having the movement in his head, in his arms, in his left arm. Okay, I think you all appreciate the movements. Okay, so this is his brain MRI, completely normal. Lumbar puncture, CSF analysis to rule out GLUT1 deficiency was normal. WES analysis was requested, but for the sake of time, until we get the results, I started him on low dose of carbamazepine, and it was like magic. So all the movement stopped, and the child was movement free. I don't know how to express how the parents were really happy with this effective treatment. So the patient was diagnosed with a homozygous mutation in PRRT2, and on analyzing the movement disorder phenotype, as I told you, sometimes we have more than one movement disorder. So the event 1 definitely fits infantile convulsions. The event 2, paroxysmal kinogenic chorioathetosis, and event 1 and 2 has been described previously in 5 families and named as infantile convulsions with chorioathetosis syndrome. Later in life, he developed event 3, which is episodic ataxia. And this is the child after treatment. And interesting enough, during the follow-up, the mother was pregnant and she gave birth to a boy, and the boy at the age of 14 months developed the same symptoms. At the age of 14 months, we started carbamazepine and he was event-free. But they didn't want to proceed for the genetic test for the sibling. Oops, I'm sorry. The other one was fine, the child, sorry for skipping the other one. Let's play this video. He was really happy. I'm tricking him to take the lollipops. Anyway, he has very good target. See? So anyway, you can see the smile of the father face. They were very happy. This is the summary, of course, of our case. So yes, it's a movement disorders, hyperkinetic paroxysmal kinogenic chorioathetosis and ataxia. No, it could not be functional. The clinical syndrome is infantile convulsions and paroxysmal chorioathetosis syndrome with episodic ataxia and genetic tests we discussed. The only important thing about this PRRT2 mutation, which is widely expressed in the CNS and it's well known to modulate the synaptic neurotransmitter, is that it can present with dyskinesia, it can present with hemiplegic migraine, it can present with learning or intellectual difficulties similar to the elder sibling. However, to our knowledge, this was the first patient to be reported having both ICCA and episodic ataxia due to this novel mutation. This is a third case of a girl whom I see initially at the age of 2 years. We did every single test to try to find out what's going on. So she will have infrequent events initially of sudden loss of balance that was mostly triggered by exercise. But these events later on becoming more frequent on daily basis, mostly triggered by swimming classes or febrile illness. And the developmental history was the only mother reportedly at the age of 3 to 9 months to have a paroxysmal eye movements that lasted for a few seconds and disappeared on its own. Developmentally, she has history of speech delay and academic difficulties. And on examination, she has low muscle tone, poor fine motor skills and coordination. And you can see how devastating this. Every single test was done. At some point, we offered the mother to do CSF analysis at the age of 2 years. She refused. She said, I'm fed up. I don't want to do the CSF. It is dangerous. But later on in 2017, finally, she was convinced, and the CSF analysis was suggestive of GLUT1 deficiency and was confirmed by genetic analysis having de novo pathogenic heterozygous missense mutation of exon 4. Again, this is how we should think about our cases. And this is the lovely girl. She's a young lady now, and she was maintained on modified Atkins DART. She showed an excellent response. However, they migrated to the US, and the last message for her mother, she sent me by email that she is off ketogenic modified Atkins diet. She's aware of her limitations, and she is maintaining her, enjoying her life. Okay, so GLUT1 deficiency, of course, it's well known that it is a disorder involving the glucose transport to the brain, and it is well known that it can present with epilepsy, movement disorders, spasticity, and mostly it is related to SLC to a one gene mutation de novo, as in our case, or in familial cases, inheritance could be autosomal dominant. Sometimes, rarely, it can be autosomal recessive inheritance. This is another family of GLUT1 deficiency, and I want to share with you, this is for some reason I will show you. So I received the patient and I followed him. He already received the diagnosis of GLUT1 deficiency. So he had the typical history of seizures at the age of 1 year, and he was started on Depakine. At this point, they didn't know what's going on. Depakine was started, he was seizure-free, and then weaned off the medication. 1 year later, he started to have worsening of seizure, drop attacks, and he started to develop movement disorders. These are dyskinesia, dystonia, and ataxic gait. He did the genetic analysis that I'll show in the next slide, and he was confirmed to have GLUT1 deficiency. The most challenging movement disorder now, as you can see, when he attempts to drink water, which is very socially embarrassing, and sometimes he would rather not to drink water, he will have this kinetic movements, which is very, very disappointing to the family. And this is how he looks while he's walking. He's maintained on ketogenic diet, but later he was switched to modified Atkins diet, and he's maintaining ketosis. He's on dipakine, acetazolamide, and cinnamon, but still his movement is not improving, and we're planning to wean off cinnamon. His girl sibling, she was diagnosed at birth, and this was very interesting. So hence the phenotypic presentation is less severe than the boy. And this is what's amazing about GLUT1 deficiency. So the boy have a pathogenic, heterozygous pathogenic mutation in SLC2A1. Both parents were negative. And when the mother gave, when the mother gave birth to the girl, she insisted to do the genetic test. The neurologist said, why should you do this? She insisted. And actually, as Dr. Maha mentioned, it could be, we have to be aware of mosaicism. Okay. And interestingly, also, the child was maintained on valproic acid, and he was seizure-free, although we know that valproic acid interferes with the transport of the, for the sake of time, this is the case summary, the last case. So this is a 3-year-old girl who had normal development. At the age of 2 years, she had her first unprovoked seizure with subsequent psychomotor regression. At the age of 3 years, she was brought for second opinion to our clinic with refractory epilepsy on valproate, lamotrigine, clobazam, and she was clonazepam, and she failed other 2 anti-seizure medications. Her seizures were described as behavioral arrest, eyelid flutter. Mother reported valproate showed the best response. However, it worsened her gait and balance. Perinatal history was uneventful except for positive suspicious screening for glutaric aciduria and non-conclusive acylcarnitine test. The first acylcarnitine test was reported non-conclusive. However, a follow-up acylcarnitine report was negative. So family history, they were first cousins. General examination, she was failing to thrive. She has microcephaly, poor vision, dysarthria, marginalized hypotonia, and proximal muscle weakness. This is her MRI that shows cerebellar atrophy, and the EEG showed multifocal epileptiform discharges. This is her workup. So the plasma amino acid showed severe serine deficiency and mildly reduced glycine. And the urine organic acid was normal. CSF amino acid showed severe serine deficiency and low serine CSF plasma ratio. Genetic test for NCL was done before. Of course, this was negative. Her West analysis showed 2 missense homozygous mutation. One is the ETFDH gene, and the other one was PHGDH gene, which stands for having the diagnosis of glutaric aciduria with serine deficiency. And this actually highlights the importance of carrying up the acylcarnitine and the urine organic acids during the acute illness. This is really very important because we can have normal results. And this emphasizes the importance of genetic tests and analysis in cases with atypical glutaric aciduria. And this is the summary, case summary, and this is the treatment. She was maintained on the lamotrigine. Dipakine was weaned off, and after that, she was much better in her gait, riboflavin, coenzyme Q, levocarnitine, and she showed improvement in her seizures and her balance and quality of life. And this is our publication. There are more cases if you are interested to go through the publication, but for the sake of time. So my take-home message, because sorry, I forgot to put the take-home message. We have to be minded with movement disorders, and we need to first to rule out treatable ones in order not to regret not to treat one of those treatable movement disorders. And this is our lovely team, and I thank you. I'm grateful. Thank you so much for inviting me.
Thank you very much, Dr. Dina. Very interesting lecture, actually. But actually, all the cases are diagnosed by genetic assessment.
No, actually, yes, it's by genetic assessment, but we have to have this diagnostic algorithm in one or mind.
Yeah, I know. The main diagnosis, we cannot judge the diagnosis only on clinical basis.
Even for those with glutaric aciduria, still we sometimes need to do the genetic test. Thank you so much.
Thank you very much. Thank you very much.
Now مسك الختام.
أنا الحنان بقى خلاص. مع بعض.
يعني إن شاء الله يعني
Okay.
بروفيسور تراب نايل رشيدي.
First of all, I want to thank all the attendees because they are staying till now and you are so tired. So thank you so much.